Dear friends, I would like to keep you for a while longer in this channel to present my ideas on retinal detachment. I know that many of you think that having initiated this concept of systematic ILM peeling in edemas and macular holes is the best thing I've done in my professional life. But when I look back on my life, I have the deep conviction that it is in retinal detachment that my physiopathogenic and therapeutic quest has been more sharpened. Alas, it is not in this field that I've been most popular internationally, far from it, and I must even modestly admit that my multiple attempts to teach the fine research of clinical findings in retinal detachment, as well as my advocacy for a surgical strategy according to this fine research, has always been a fiasco. Why did I fail to convince? First of all, because the subject is no longer fascinating. 30 or 40 years ago, retinal detachment surgery was the main activity of retinal surgeon and therefore his main interest, as can be proved by the huge number of scientific publications on the subject at that time. Today, since the advent of macular surgery and AMD treatment, this surgery is still as time-consuming and as low-paying as ever, represents only a limited part of the retina surgeon's activity and is therefore no longer his main interest. The second reason why I did not succeed to convince is related to the fact that the strategy I taught is based on a very precise analysis of the relationship between retina and vitreous. Analysis made very difficult for those who do not use the optical cut provided by the slit lamp of the biomicroscope or the operating microscope. And this disturbs and distances all those who examine their patient in indirect ophthalmoscopy. That is to say, the vast majority of operators. If we add that this analysis is not so easy to acquire, and that the use of the microscope for external procedures is considered by some, even nowadays, as completely superfluous, we can understand why there has been internationally this rejection of a strategy that is scientifically, technically, or morally demanding. Because it's so much less demanding for the operator to opt for a systematic strategy. I'm not talking about, of course, the systematic buckling that nobody can defend today, as there are so many cases where it is not necessary. I'm not talking either about the systematic attitude aiming to increase the surgical trauma at each failure by successfully performing a localized buckle, then a cerclage, then a vitrectomy gas, and then a silicone oil injection. A failure is not necessarily more severe than a first procedure detachment, and even a third failure can be due, as here, to a very small tear anterior at 1230 forgotten during vitrectomy. No need for silicone oil. A simple cryogas will solve the problem. I especially want to talk about systematic vitrectomy. It is so cool to do a vitrectomy. In addition to certain scientific problems which cannot be treated without a prior vitrectomy, it can transform a detachment by vitreous traction into a simple detachment without traction at all. It also has so many advantages. pre-operatively. There is no need to fret over looking for all those details that allow us to understand the pathogenesis and the evolution of the detachment, since in any case the strategy is already fixed. There is also no need to look for the smallest dehiscences, since they will be discovered during the vitrectomy. During the operation, no need to learn how to localize tears and to make a buckle. Besides, does the new generation of residents still knows what is it? Is there still a teaching of buckling technique? These techniques which require to master these gymnastics which allows to pass from the internal view to the external view deviate so much from the habits that we take with the anterior segment, where everything is managed at internal level of the eye. No need to know how to perform an external drainage or a cryotherapy. The subretinal fluid will be aspirated through the tear, perfluorocarbon will be injected, a laser will be done, and that's it. No need to learn how to manage the problem of available space, for example, to gas injection. Vitrectomy will give all the space you want. Finally, since the vitrectomy is done with the help of the microscope and often avoid performing external procedures, the presbyopic surgeon will no longer have problem in the near vision. And post-operatively, having opted for a systematic vitrectomy will, in case of failure, protect the operator from a difficult feeling of guilt. He no longer has the impression of having failed, since he has obeyed the guidelines indicating that any detachment must be treated by vitrectomy. This touches on a psychological domain that is difficult to quantify, but we have all experienced this feeling of guilt in the middle of a PVR dissection that goes badly, where the decision is made to inject silicone not for the sake of the patient, but to clear ourselves of the failure. It is so much more difficult to tell a patient, I opted for a procedure which unfortunately did not prevent the loss of your eye. And so much easier to say, I carry out the recommended procedure that unfortunately did not prevent the loss of your eye. This is the subliminal message that escapes from this video, What a Wonderful Job, that you will find in the playlist. So you see, there is a lot of benefit by doing a systematic vitrectomy. Unfortunately, everyone knows that in the case of a retinal detachment, a vitrectomy must be very complete, especially if you want to avoid external procedure. It will therefore carry with it, in addition to the risk of cataract, a certain number of complications such as iatrogenic tears in 10% of the cases, according to Klaus Luke, vitreoretinal canceration, endophthalmitis, and so on. All these complications that added together mean that in the majority of primary procedure detachment, the systematic use of the vitrectomy does not allow better results than a simple buckle. The SPR study, bringing together 46 surgeons from 5 countries and drawing lots either a buckling or a vitrectomy, indeed showed the absence of significant difference both in terms of final anatomical result and recurrence rate. Admittedly, only 681 patients were included in the analysis, but still, one might have expected that the systematic vitrectomy would have been more effective than a systematic buckle. In fact, the big lesson of this beautiful study is that retinogenic RD does not accommodate a systematic strategy. Why? Because detachment is a complex and multiple disease. Certain clinical findings call for a vitrectomy to achieve healing. However, for some other detachments, the only way to cause failure is to perform a vitrectomy. We must therefore adapt our strategy to these clinical details. But to prove the superiority of a strategy modeled on these clinical details, it was necessary to organize a multicentric study taking into account these clinical findings to know if they influence the final results. The problem is that to be able to make a comparative therapeutic study according to clinical detail, an infinitely larger number of cases than for the SPR study had to be collected. This is why I organized in 2011 the EVRS retinal detachment study, the largest global statistic ever made in this subject. 7,678 retinogenic RD, more than 11 times more cases than in the SPR study, all primary procedures, stage 0, A, B, and C1, and addressed by 180 surgeons from 48 countries. This number of cases, countries, of doctors working in public or in private institutions and using different machines made it possible to reduce the statistical bias. The disadvantage of this study is that only 18 variables could be studied. Although it was possible to differentiate between radial, segmental, or 360 circular buckling, we could not analyze the result according to the buckle material used or the suture technique employed. Certainly, we could analyze the result according to 3 vitrectomy machine parameters, but how to analyze the correct realization of the posterior haloid peeling? Same thing for laser retinopexy, confluent or not. In fact, each surgeon having his own little tricks, different from the neighbor. This study lacks a little homogeneity and is in fact the reflection at a time t, of which result a standard technique will lead to based on clinical findings more or less rightly appreciated. As you will see, many surgeons among the 180 did not differentiate a traffic hole from a tear whose flap has been ripped off, simulating a hole. This is why I will also present you a second statistic, which is a personal statistic on 4,770 consecutive regmatogenous RD I operated on from 1983 to 1999. Note that in this study I have integrated an additional stage, the stage 0, which I created in 1985 to designate the so-called retinogenic detachment, marked by the absence of intravitreal pigment. And that stage C1 to C4 correspond to an anterior or posterior retraction spread over an angular cumulative surface of less than 90, 180, 270 or 360 degrees. Finally, to solve the problem of eyes where the silicone oil is injected and never removed, I arbitrarily considered in this study the silicone injection as a failure. But the advantage of this study is its homogeneity, because during all this period I did not change my philosophy, strategy, retinopexy, drainage, tamponade, backing, and I always use vitrectomy machine equipped with the aspiration flow control. The second advantage is that at that time the limited number of retinal surgeons in France allowed me to receive detachment from 500 referent ophthalmologists, and therefore to have an exceptional high rate of primary procedure detachment, giving an epidemiological reflection of standard detachment in France, and therefore allowing me to offer you an epidemiological RD distribution very close to the truth. The disadvantage of this study, apart from its retrospective aspect, is the huge bias brought by the fact that I was the only operator of the study. To enable you to immediately identify which study a slide refers to, you will see two different logos in the upper right corner. I propose that we take a long journey together, analyzing in turn the clinical details, allowing us to understand the pathogenesis and the evolution of the retinal detachment, the unknown factor that persist, and the repercussions that these details will have on the final result. This will allow me to show you that a non-systematic strategy modeled on clinical detail is statistically significantly much better for the patient, both in terms of percentage of anatomical healing and in terms of functional recovery. You will see that the results of my personal statistics are better than those of the RD study. This is, in my opinion, because I learned my ophthalmology with Mireille Bonnet, who founded a school based on clinical finding research. I continued this search for clinical details, and as I have been always interested in physical laws and fluid dynamics, I developed surgical techniques independently of international trends to better stick to the clinical findings requirement of each detachment. This is why I will have the immodesty to show you how you can further improve your results by optimizing your drainage, retinopexy, tamponade, backing procedure, or vitrectomy techniques. But be sure that this is not a simple and peaceful route that I propose to take. This philosophy is demanding. You will be in the grip of doubt, especially at the beginning, when you make a small indentation of 20 degrees for a total detachment, or when talking about the more or less active character of a vitreous traction, you will be faced with the misunderstanding of all the indirect ophthalmoscopy users. But you will have this feeling of understanding of the pathology. And finally, cherry on the cake, you will share with me statistics like this one, where on 2,300 stage A detachments, the number of failure of silicone oil injection was less than 1.5%, and the rate of visual recovery equal to 83% of visual acuity present before detachment. it will not make you richer, but probably happier.